oncology, it is not about cutting, surgery, just chemo, radiation. To understand, counseling, pain palliative medicine, hospice care, supporting the family both emotionally, keeping their quality of life in mind. Otherwise, all the value of the treatment we give has no importance. So today we have a fantastic topic to be covered, which is very rare. Very few people in India can cover this topic. So we have Dr. Raghavendra, who heads the Department of Pain and Palliative Medicine at Aster International Institute of Onco. This is one of the very few ESMO recognized center. So today he's going to share what is that every surgical oncology student should know about pain and palliative medicine in oncology practice. Thank you very much, Raghavendra, and welcome, and over to you.
Thank you, sir. Thank you for those kind words. I thank for this opportunity also, Sonshekar sir. And today's topic, which is going to be covered in the next 40 to 45 minutes, is going to be pain and palliative medicine specific to oncological practice. Yes, pain and palliation is just not for oncological practice. It can go for non-oncological concerns and issues also. So therefore, I'm going to restrict my talk only to oncological practice. The agenda is, we're going to go through, these are some of the headings which we have here. We're going to go through all of them one by one. The objective is, as Somshekar sir told, all of you are trainees, and you should have the basic concept, and understanding this concept and actually putting it to clinical practice is what is most important. I think getting into the nitty-gritty of specifics and others could be learned over a period of time, and your own clinical practice will evolve with it. So hence, when you're getting trained, if you have the right kind of understanding of what these concepts are, which is going to change your clinical practice per se, or the outlook towards managing your entire patient over the next period of 40 years of your practice, it's definitely going to be the most important of all. Now, oncology has actually evolved multiple times over and over again. And we have actually gone into precision medicine, wherein it is very, very specific to an individual. Could be towards a case, could be towards a specific disease. And in that individual, if two oncological concerns are there, you want to handle it differently, or what it's going to be is something which you could actually be as precise as that. Now, to actually handle a human being from the perspective of disease, is that enough, or is it something which is beyond disease over here? Now, all of us used to talk about precision and doing disease management is what it's all thought about. And why discuss palliation? Now, is it actually having to meet ends over here? Is it something which is important, or is it just an aspect of hand-holding, as palliation is most of us have thought? Somshekar sir has actually put across perfectly over here. Radiation therapy, surgeries, immunotherapy, it could be your graft-versus-host reaction after a transplant, or it could be chemotherapy itself. None of them come without a concern, an issue which the patient or the family has to deal with. It could be as simple as xerostomosis, wherein you have dryness of mouth. That could be a concern for me to talk also. And these are the side effects which can start from head to toe. As simple as that, going up to severe pain in oncological practice, iatrogenic itself. So therefore, they're not just dealing with a disease. The treatment of the disease itself could actually have a lot of impact and implications for the patient as well as the caregiver. I'll come to those in the next few slides. Now, palliative care as a concept is widely misunderstood. Most of us think saying that it is hospice care, it's hand-holding, it's just communication, it's counseling. Is it just going to be end-of-life care, wherein you're going to give some medications and the patient is going to die? Is it going to be there, or is it going to start from the day a concern or a illness is actually diagnosed as a trajectory is important? So here we are going to have the myths debunked, and the reality is something which we're going to look into over the next 40 minutes. The biggest of all is people care, or palliative care is only for people who are dying from cancer, and it's only for death or after death is what the concerns is, or consensus to a large extent, or the misnomer or the misconception, even in the developed countries. Now, this is something which is to be changed. Now, I'm going to the basics of what is a human being going to function as. Now, the functionality is very, very important because it's just not the body structures which we are important of. Now, body structures can get into a disease, yes, but is this disease is going to affect his functions, or the functionality is already affected by his comorbidities and others, inclusive of his psychological functions, which are very, very important. If he is a very bold person, he will face with any form of challenges. If he is not, he's not going to. The same way is how the body responds and reacts over a period of time also becomes very, very important. Now, these classifications not only actually affect them in all senses, their activity and participation, socially being there. Now, structure, function, affecting their socialization. So we have got the psychosocial model, or the concern that it is just not a physical concept is already put across for understanding, as well as we have to have a personal factor which is affecting them multiple times over, as well as the environment which is surrounding him. It could be the entire support system he's got. And mind it, healthcare professionals, I'm talking about not about only oncologists, anybody who's come in healthcare will be all as a part of these environmental factors. Now, all of us talk about overall quality of life, and this is something which is a bigger concept. Now, once we have to have, I just spoke about what is health-related quality of life, and this is the revised Wilson and Cleary model of health-related quality of life. That is, your symptoms have to be managed well, your functional status has to be brought back to your concern wherever the disease had affected, and get back to it as early as possible, as best as possible, and getting back to what you can do with the concepts of general health principles, not forgetting whatever's affected them before. And mind it, it's just not physical here. You can see that it is not only the individual which he has to part as a partner in this team effort. You have to have all of us who could create this environment for him to become better. And this is what is most of it becomes health-related quality of life. From 2000, WHO has been very strong on actually putting across health-related quality of life as important, and has told saying that the patient himself is going to determine. That's why we have all the scales which the patient or his attendant is going to put across about health-related quality of life. And why are we as healthcare professionals? Absolutely, we have to improve this health-related quality of life from where we have actually picked them up, and the entire journey, whether it is transition into the better care and improved and better outcomes, is something which is important. And these clinical outcomes become very, very relevant over there to actually improve the quality of life from the perspective of health-related quality of life. Now, symptom control. Any oncology patient would have multiple symptoms, as you all know, are aware of. And improving quality of life, I told, is not void if we don't look at the health-related quality of life, not from just the physical aspect, from the entire other perspective. Now, longevity of life. I will just take some more slides to actually tell, saying that how health-related quality of life or quality of life has improved, just not the aspect of disease management. It's actually improved the longevity of life. Now, healthcare utilization, optimization, multiple visits to hospital, multiple admissions in the ER, getting the strain on the healthcare professionals, that's our own colleagues in the ER, in the ICU multiple times being admitted for when the patient has got futility of treatment. These are certain aspects which not only is going to affect the patient and the family, is going to in turn affect us also as healthcare professionals, and we are going to be specific when we are dealing with this. End of life care, bereavement, patient and caregiver satisfaction. These are all the specifics which have been determined in clinical outcome. We can actually talk about pages together, or multiple episodes could be dealt with this, and each one of them is specific to palliative care. And this is where we have to start, and the concept has to build, saying that we are going to improve the health-related quality of life, just not the disease factor is important for us. And for that, none other than the actual getting up the team to actually have the pain and palliation teaming effort towards this improvement, and working as a team side by side with medical, radiation and surgical oncology is utmost of importance. Now, all of these outcomes, either it could be patient-related outcome, clinical report, clinician-reported outcome, observer-reported outcome, or performance-reported outcome, Now, all of this could be actually put across or brought about by various people. The first one being the patient, the clinician is the second, who is the observer, who's unbiased of it, or it could be the patient's attenders themselves from the performance outcome and aspects. Could be the clinician also becomes very, very important. And these aspects have to be looked into. I'm not saying that oncological practice will not be considering. It is definitely going to consider. But how do we improve this? We have to look at the entire aspect of managing these, giving importance to health-related quality of life from the day one. As much as aggressively we're managing the disease, we will have to look at the symptom and other management so that we get the better outcome for these patients and their family. Now, understanding, is oncology a different aspect compared to what we are actually teamed up? Why don't we require pain and palliation in an acute scenario? Now, oncology, all of us know, is not an acute kind of a scenario or an acute kind of a disease wherein you have come, you have assessed, you have diagnosed, you advise and treat. Absolutely not. It has to go on because it's not a one-day program or a one setting program in a hospital. It is actually at multiple settings, multiple admissions, multiple discharges at various levels, OPD, IPD, it could be ER, it could be in terms of the ICU, going back home, going back into the community. So we actually need to incorporate not the acute care model. Most of our hospitals are equipped to look after acute care model. But what we are looking forward to in the next 15 to 20 years plus is the chronic care model. And chronic care model is assess, diagnose what is the problem, what's the disease, advise, but you can't treat here. You have to communicate to them, and communication is crux. And this takes a lot of importance. When you have an oncological thing, you have a life-limiting illness which needs to be communicated, it becomes a big blow, not for the patient, for the family. What's going to happen to me, my family, what's it going to be? And here is where exactly the pain and palliation could even be initiated. And it could be assisted, empowering them, not the patient, as well as the caregivers, how to deal with each scenario from the patient's perspective of his managing his symptoms, his disease, taking the journey across and making him feel saying that he's looked after, he's very well addressed and cared. Arrange at the various levels. It could be the different departments in the hospital or going back into the community is the continuity which is important, and it goes on because we have a treatment going on. There are going to be concerns and problems, and again it goes on to all of this. I'm sure all of you would agree that this was one of the paper cuttings which had come up in 2022 saying that chemotherapy at home, doctors have debated how safe it is going to be. If we are talking about chemotherapy at home to actually improve health-related quality of life, that therefore the patient does not visit hospital multiple times, this is where we are going to, and this is something which has been debated in Mumbai. Are we actually lagging behind if we don't talk about pain and palliation specifically from the day one? Absolutely yes. So in terms of this, we are going to actually have a wonderful definition which was put across by WHO long ago. It's about providing symptoms, for assessing the right way and actually getting those distressing symptoms to the best of the possible to be curtailed at all phases of his treatment, affirm life regarding death as a normal process. Once a person is born, he has to die. And if, unfortunately, if the diagnosis itself comes late in our own patient who's actually coming to us, majority of them who come in our country would be coming in the third or the fourth stages to a large extent, could be 50 to 60% plus of them will be there. We are here not to hasten or postpone death. We are here to actually make them best to the possible and actually have their life to be actively lived as possible until death. Now, palliative care benefits are multiple. I've already spoken about health-related quality of life. I've spoken about quality of life, how it could be improved. Now, going to the nitty-gritty, physically relieving all his symptoms and discomforts, psychologically to provide emotional and mental support, spiritually empowering, finding purpose and a closure with everybody. Now, it has to be a specialized palliative care. It can't be a generalized palliative care when you are doing precision oncology and you want that kind of specificities happening side by side. You have to have a specialized approach itself. And is it going to affect his economics? Absolutely. multiple admissions into inpatients, daycare, home care could all be there, which is going to be taken care into. And palliation is not age limited. It could be pediatric, geriatric, it could be any activity related, is not specific. It could be across all the spectrum. It's not only for an organ. So therefore, I'm talking about any form of solid organ or hematological diseases I'm concerned over here. Location, it could be applicable to intensive care or ER. I'll come to understand in the next few slides. So if you have any age limiting illness, any age group, any location, you have a life limiting illness, definitely there will be symptom burden and you will have to have palliative care as a concept going on over there. Now, what are the values and goals as a palliative care physician or a palliative care team you will have? First centric is patient as well as his relative. We are not going to put across his extended family to any abeyance. We are going to put them all together, and this is something which is going to happen. Respect their values, active conception is there, trust has to be built, honesty and integrity. Now, these are aspects which go as we actually take them ahead. And once we value their thoughts and concerns, it is going to be much, much better as all. And all of us know saying that understanding life-limiting illness or getting to accept itself is a big, big problem. And there are 5 stages of grief put across by Kubler-Ross. First, you go into a denial, then you can go into an anger, then bargaining, depression, and finally acceptance. So hand-holding them where they are, how they are, is all specific, is scientific, and it's evidence-based. And this is something which is very, very important and the crux to all the palliative care group team I'm actually talking about. Now coming to where is the treatment? How is it going to be that the palliative care group is going to actually be working in the hospital? All of us are aware saying that it starts in end of life care, and end of life care is something all of you are very well aware about. What does happen over there? It's just symptom control. I'll come to the next few slides. What is symptom control? But you could actually have home or hospice. End of life care or active dying is where is the last 72 hours, and we encompass only of managing symptoms over here. Whereas in the home setup or the hospice care, we are going to look into symptom control as well as supportive care. And symptom control is something which I will mention what are they going to be. But in an acute hospital setup, as Somsekhar sir had just mentioned, it's disease management side by side, supportive care and symptom control all taken together. That is how the health-related quality of life is going to be much, much better starting from the day one. And the patient as his family will understand saying that these people are hand-holding us and these are going to be much, much different from any other way of actually letting out. That's exactly what I mentioned just now. And all of this in a hospital, it should have a continuous care and at different settings, as I've just mentioned. Communication becomes crux and it is multidisciplinary input. So actively participating in all of the tumor board meetings, understanding that person and the patient, giving inputs from our end. How is his psychological makeup? How is his spiritual makeup? What is it going to be? Will he be able to accept his surgery? Will he be able to accept this chemo? How is he going to actually fare better with the family support? Whether the support is okay or not, is all becomes very, very important over here. Now, the old approach of palliation was life prolonging measures. That is when you would actually refer and you're going to have the hospice or benefit or things. But the new approach is, it's already started about 2 to 2.5 decades ago, that it starts with the diagnosis of serious life-limiting illness. And palliation is going to increase as you are actually putting across life-prolonging measures, and that is not going to work. And as much as it's not going to work, the palliative takes up the full concept over here to support the patient and his family members. The end could be wherein I just mentioned, wherein supportive and symptom control happens over here. That is hospice as well as home. I will just come to that, why home is much better than hospice care. And the last is, we don't let the patient's family, when they've lost a loved one, we're going to go into bereavement, look into how they are actually coping, how they are better, how they are going to framing. It's all important over here. So I just mentioned it's integration, not just into the OPD or clinic or hospital. Hospice is the Western concept. And is that something which is culturally acceptable to our own group or our own nation? Home care is something which is much, much more better accepted, being that we have not abandoned the loved one. We have not put them somewhere else. I am taking care of my kith and kin, my father, my child, whoever it could be. And that becomes very, very important. I'm not telling Western is not right in putting across hospice, but I'm saying that this is what probably if you have a nuclear families which are occurring now and later on, this might be the concept which might be there, going to involve and going to be culturally accepted by our own group of people in our own country. But at the moment, I think home care is something which is better. Now, I did mention about symptom control. These are the few symptoms which are there. The 5 cardinal symptoms are pain, breathlessness, nausea, vomiting, constipation, delirium. Naming a few, fatigue and sweating is something could be very trivial for us. Itching could be trivial for us, but for a person who's undergoing it is going to be really, really reckless, and the patient is going to have real concerns, as well as affecting the patient's family, because it's not a one-day program. It's going to go on. Now, supportive interventions. It could be emotional, spiritual, or psychological. Control of fluid electrolyte imbalances, specific to hypercalcemia, hyponatremia, hyperkalemia. These are all part of patients who would actually be coming to a hospital for admission for supportive care. Now, variables could be transfusions, infection, tube feedings, dialysis, TPN. Dialysis is something for a patient who is actually terminal, but still would actually have a life event which is going to change, celebrating somebody's wedding or being present at the birth of their grandchild. These are certain things which are very, very important, and special occasions wherein you will individualize the treatment concepts to these group of individuals based upon what they are going to be. Now, I had mentioned before that integrating services across all care is important. And this has been a paper which has come up long ago in Journal of Emergency Medicine, about almost more than 2.5 decades, that integration of palliative care into emergency medicine, improving palliative care is important over here, as well as in emergency medicine also. So we have to implicate this everywhere, across settings, in the hospital, which is accredited towards managing the person to improve just not the disease, it has to improve the health-related quality of life. Now, all of us would actually be looking at this. Just taking a jab is going to be very, very difficult, and the patient might scream across, might be very, very upset, and things like that, because the perception is it is going to be a difficult thing and learning event for them over the entire life, saying that injections are going to be terrible. It's going to be put across by the mother for the child over a period of time as a child growing up. Now, that's the same concept which isn't going to be changed. You look at this lady who's actually lying down comfortably, 1,000+ jabs over here. But the perception is, I'm going to have this tattoo done for an event, for somebody else, for my own happiness, to show somebody saying that I love, appreciate whatever they've done, and the happiness and joy over here. So pain is just not a symptom. It is going to be a concern which is not going to be just affecting him physically. It is going to affect him emotionally, psychologically, socially, not participating, not going to be active. Now, Dame Cicely Saunders was the first person who put across the total pain concept in 1964. She was a social worker to start off with, graduated to become a nurse, then went on to become a doctor, and finally she was actually practicing Catholic. So therefore, she put across all these concepts, and she could see that in a chronic trajectory of a disease management, we had to go across all of this. And health-related quality of life, which is actually put across in 2000, does it actually spare this? No, it has incorporated all of this. So the basic foundation of palliative medicine itself starts from the entire improvement of health-related quality of life to a large extent. So it can't be spared at all at any point of time. Now, getting the analogy clear. Now, you had a patient who was there, was just taking just a small jab, and an injection made her scream, cry, do things. And another person, 1,000 jabs for a tattoo, but she was happy over there. So emotions are very, very important. And look at this person, is hanging from the pole, and it is something which is going to be spiritually cleansing for him, a thought, what is going to be there. So a person who comes to you might actually say, I've got severe pain in my arm, head, or anywhere. But if you don't find the physical concept, please do not ignore that, saying that this patient is just lying. It could be not physical. It could be psychological distress. It could be social distress. It could be others which needs to be specifically looked into, diagnosed, and appropriately managed. And who is going to partner you in that? It's going to be pain and palliative care team. Now, we know that we have moved in pain and palliation as oncology is moving from a smaller stage to a precision oncology. We can see that we have moved from a small mechanical syringe driver, which was used in the end of life care, to syringe drivers in the palliative care in the hospital. Have we moved ahead of this? Absolutely. We have gone into what is called as GPS enabled PCAs. So we will be able to send them home. Now, this is very, very important to actually manage a person who's actively dying at home, as well as in the ward. Post-surgery, it could be. Post-chemotherapy, it could be post-mucositis, post-radiation, head and neck cancers, or could be anything wherein a patient has got severe symptom burden. Could be agitation, delirium, restlessness. We could use these concepts over there and actively be as aggressive as possible in the hospital setting, as well as in the home setting also, if it is going to be enabled as a team over here. Now, we know saying that opioids, narcotics, pain management is just not opioid the mainstay. Yes, WHO ladder actually encompasses almost 80 to 90% with these simple steps, and all of us could incorporate this, giving medications. And once the quality of life gets poor because of multiple medications, polypharmacy, leading to a lot of side effects, then we need to actually look into what best could be done. Now, the appropriate understanding of pain or any other symptom specifically is very, very important. And gone are those days wherein we are just going to be, as opioid mills, just giving opioids to all patients. If we have a right full diagnosis for a head and neck cancer patient who's actually post head and neck cancer, and he's actually having severe pain, neuropathic pain because of his neuroma formation after a mandibular nerve, mandibulectomy or a maxillectomy, definitely we can go ahead and do a Gesserian ganglion radiofrequency ablation, or we can go into celiac plexus. Now, far better than celiac plexus, we are doing splanchnic nerve ablation. Celiac plexus was done for patients who were terminal, who were not going to be there. Yes, the evidence is very good, 2A+. In an interventional thing, it is going to be the best of all. The same concept applicable to the splanchnic nerve RF ablation with alcohol is going to be much, much better, because patient is not going to have fibrosis of whatever you've ablated into the intestine. So you can do a surgery wonderfully, you could take it ahead, you could do chemotherapy, and the survival and the quality of life, that is HRQOL, is going to be much, much better for this. Now, does it start and stop to actually give celiac plexus? No. But the right kind of diagnosis, a clinician hand-holding this is very, very important. Patient might be in malignant bowel obstruction. And am I going to do a celiac plexus block over here? No. We are going to diagnose this and actually look into whether it's going to be just fluid electrolyte, which is going to be imbalanced. Hypokalemia, is it going to be, or if fluids are less or over fluid? Is it ileus because of multiple issues? Whether this electrolytes could be corrected and taken into consideration. Hypercalcemia management also could lead to a lot of constipation, nausea, vomiting over here. Is a TPN important for this patient at this point of time? Is there going to be more surgery done, more chemotherapy done? What is the stage of the disease? Individualizing those plans are very, very important, as well as not sparing the family, understanding what they are thinking of. Inclusive of their economics, it becomes very, very important. Who is going to be partnering over here? Again, pain and palliative care team is going to partner you through and through. Now, diagnosing this could be clinical. Yes, X-ray also is there. But the new concept has evolved already. This is one of the review articles which I myself have written as a group over here, wherein getting ultrasound, that is point of care ultrasound into palliative medicine. So we are doing partnering at the hospital level, and that is something which has to be aggressive, time bound, and actually being there, partnering you side by side, shouldering you with evidence is something which is important. And that is where this concept becomes important. So it is time to focus that palliative medicine should incorporate concepts of point of care ultrasound, because time is king over here. This is the only instrument which can replace the stethoscope in the next future. It will acquire an image, interpret what the concern is, diagnose, as well as intervene at the same time. It could actually be used for prognostication. I will come to the next slide where we can use prognostication. and being cost effective. That is, patient is not moving multiple places, no multiple imaging. If it's patient is in end of life care, or a pleural tap has to be done, or ascitic tap has to be done, or an access has to be obtained, all of this could be done at the clinical base setting itself. Now, I just mentioned about prognostication, getting the focus into palliative medicine. It gives about not only about understanding the diagnosis, predictor of 3-month mortality. Now, muscle ultrasound, measuring the thickness of your rectus femoris muscle, will be much more accurate in understanding your cachexia, sarcopenia. That is the most important of all the answers which is related to health-related quality of life, as all of us know. And that is something which is the way ahead for pain and palliation. Now, this is something which was published, and conclusion is findings revealed that combined use of the efforts of the PAP scores, the palliative prognostication index, palliative prognostication, as well as muscle ultrasound, predicted the 3-month mortality much better compared to just using any one of them. So prognostication is also a part of pain and palliation aspect. Now, coming to some of the evidences. Early integration of palliation. This was a review article which came in Supportive Care and Cancer, that survival is actually going to be improved. There is enough and more evidence already that integration of early palliative care is going to improve quality of life. How? HRQOL. So you're improving HRQOL and overall improving quality of life for that patient at point of time. Now, it was just some evidence before. Now it has come as a guideline. This is ASCO, a guideline which has come up in 2024, which saying that it should start from the beginning of any form of oncological practice, may it be solid organ or hematological. Wherever there is uncontrolled symptoms, there will be quality of life concerns. So therefore, integrating pain and palliation from the day one is going to be much more beneficial, not just improving quality of life. I will put across, if you improve HRQOL and quality of life, this was an article which had come up almost a decade ago, and this is in a group of head and neck cancers. They had studied these 200 patients over 10 years, and it is a strong association that if you improve quality of life after treatment, the long-term survival just with improving quality of life is going to be much higher. As well as this was one of the index articles which had come up long ago, about 1.5 decades ago, by Jennifer Tamel et al. In New England Journal. That is just applying the principles of palliation, not changing anything other than applying principles of palliation. In a group of 151 patients was the study number. It improved survival, that is longevity. So 11.6 months was the survival in comparison to 8.9 months in the standard group. So therefore, we see saying that palliation improves health-related quality of life is improved, survival is improved, as well as longevity is improved. Now, all of this have been proved, and it is now in the guideline. Now, once we improve their survival, does palliation stop there? Absolutely not. Survival of cancer is just not the ending of a gruesome travel. It's the beginning of a beautiful new life. Is there any role of palliation in survival itself? Absolutely. And one in that is every 3 patients. This was an article which was actually put across by American Cancer Society way back in 2019. The prevalence is almost 30% is what they had mentioned. Now, is that changed? This was a systematic review with a meta-analysis which has just come up in 2022. The prevalence of patients who have survived, the prevalence pain is around 44.5%, almost 50% of the patients. And moderate to severe pain is experienced in 30.6% of patients. Now, who's going to handle all of these? We will have them. If we don't put this across, we will going to be actually falling short of improving all. Now, pain in these cancer survivors are multiple. You can see that it could be because of surgery, it could be because of neuropathies, it could be radiation or direct tumor effect. All these things have to be looked into even after survival. It is not done. So WHO has put across saying that you have to integrate rehabilitation services. And this is what is going to enable a holistic improvement. That is from the day of start, and you're not going to leave them anywhere. You're going to take them ahead along, making them back to their work and improving them. This is one of the review articles which I had written way back in 2020 itself as an editorial, and it becomes very, very important to incorporate both these concepts, palliative rehabilitation. And is that important? You all would actually concur with me after all these aspects. Now, I have not forgotten the home care or the hospice setting which Somsekhar sir had mentioned, and all of you know. In Aster, you've done something which is much, much better. There is something called an Aster Care Extended, and we name it ACE. The reason being is home care could be a generalistic provision. It could be home care for an elderly geriatric patient. It could be somebody who's actually ailing with multiple things, might not have a life-limiting illness at that point of time. But for a person who's having oncology, as I told, it has to be specialized and it has to be precise. As we had discussed, it becomes very, very important. Why we have changed the concept of home health care to Aster Care Extended is, it is the need, the unmet crucial needs which are there, that is the patient as well as the family understand saying that the constant specialized care and support is there with me, and the follow-up is actually coordinated and monitored. Every hand holding becomes very, very important, so that outcome, I'm not left, that outcome becomes much, much better. Your symptoms, that is pain, anxiety or trauma, becomes less. Quality of life is not getting affected, and keeping them home, the cost price comes down. So therefore, escalated costs are not there. That is, admissions and readmissions to specialty hospitals are not going to be there. So ACE could actually bridge these gaps in consensus with the neighborhood clinic, neighborhood doctor, GP, anybody who is going to be there with a person who is going to take care. Now, all these are possible by televisits, collaborating the workflows at one go. Unless and until we don't work as a team, we might actually not be doing justice to the patient. So supportive group, that is the healthcare professional group, could be pharmacy, could be medical support, could be in terms of logistics, could be in terms of supplying medicines, getting lab investigations and others. All should be done so that we could be able to do this as a seamless maneuver for the person who's not going to be left alone at all at any point of time. So even physiotherapists going home going to be there. Now, I'm not going to let my talk end without understanding. All of us talk about health-related quality of life, having a good life. There are very few people who talk about good death, and pain and palliation will never shy away. Putting across that good death also becomes very, very important, because what is going to be in the patient's attender's memory is going to be good death, and that is something which is going to go for their life, and it is going to affect them. Now, India, where do we rank? There was a quality of death index, which was actually a parameter which was driven in 2015, a philanthropic society from Singapore, that is the Leans Foundation, from in consensus with the economist special intelligence unit, looked into the various rankings and actually gave 80 countries where do they stand based upon healthcare environment. We stood 51 out of 80 countries, quality of care 59th, availability of end-of-life care 67th. So overall ranking became 67. I'm not sparing this cost of end-of-life care in an ICU wherein it might not be required at all. We as doctors have taken an oath saying that we are not going to do which is going to be unnecessary for our patients. So unfortunately, if the patient's attenders are not given this concept that we're going to handhold them at home, then it is not going to be beneficial, is something which they will accept to from the day one. Then they are going to come to the hospital and they would force them to actually be admitted in ICUs, which is going to be very, very traumatic, not only for the patient, for us also as team members who are going to take care, who could be actually, that bed could be provided to somebody else who could benefit from it, is something which is already there. Now, in 2022, the same 2015 group of countries were actually looked for quality of death and dying in 2021 based upon around 12 principles of quality of death. I'm going to come to those quality of death. You can see that managing pain and discomfort becomes utmost. And over there, we have improved from the 67th position to the 59th position. You can see here, we are in the 59th position amongst the 81 countries. Now that's a good jump which we have made because great to advocacy, learning and putting across into clinical practice. These are the following steps which were actually put across for a good death. That is, end of life decision making is a process, so it should be given adequate time, adequate importance, and how. And it has to be started from where the patient's disease is actually not getting controlled in the disease trajectory itself. Recognize the dying process, making them aware, initiating of end of life care pathway when there is active dying going on. During the process of end of life care is very, very important to actually have anticipatory medications, where they're going to be, what it's going to be, and what is going to be the after death care. Is it going to be in hospital? Is it going to be in home? Ambulance services, giving death certificate. This becomes very, very important. I'm sure in your clinical practices, you would have definitely been better off in all of these things. Now, is there evidence? Absolutely. Clinical practice guidelines, ESMO guidelines have come up way back in 2014 itself, saying that advanced care planning is something which is important. And in our own country, the Supreme Court last year has come up with all these aspects incorporated, the 5-bench judgment saying that it is important to have this. And did we have a clinical guideline? Absolutely. End of life care policy for the dying has been put across. This has been published in 2014 in the Indian Journal of Palliative Care. ISCCM, the IAPC with consensus also have come for critical care medicine. For pediatrics also it has come up. So multiple guidelines, multiple papers are also there, and the judiciary is also working with us to make this happen much, much better. Now, these are small aspects of good death. That is, to know when the death is coming, retain control of what happens, dignity and privacy, control over your symptoms, where the death occurs. If the patient prefers to go home and if he's aware of it, definitely, yes, we should actually enable that as much as possible. Given information, get an understanding if an expertise is required to be actually looking at them at home, is something which can extend care is there. Wishes to be respected of the patient as well as the family members as much as possible in the context possible. Who's present, who's going to be sharing the end is a patient should decide. Not to have life prolonged endlessly or pointlessly. Now, you could have all of this being put across and still symptom not being controlled. And if the patient is in active dying phase and the symptom needs to be controlled, palliative sedation becomes very, very important. I'm not talking about we have not done anything. Even intrathecal analgesia, that is, if you put a morphine pump into the intrathecal, there are patients who could have pain. And this is something wherein a concept is there. I understand it's going to be a very few percentage of people. You will have to have this concept, and it is a doctrine of double effect which is going to be covering us as far as possible over here. I think getting into nitty-gritty of that becomes very, very difficult for me. I've got another 2 or 3 slides. I'll finish them and I'll open the chat box for question and answers. Now, bereavement. Once the patient has no more or the loved one is no more, you need to have the support going on for the family because they've gone through a life-changing situation over here. The ordeal is going to be too much impactful over a period of, could be around a year or year plus, or a short period it could be. So it depends. Now, WHO has definitely put across saying that it is a recommendation that palliative care must include bereavement services which are adapted to their specific faith, culture, and individual preferences of the loved ones experiencing the loss. Now, is there a guideline to it? NICE 2003, way back in 2003 itself have put across that the level 1 support is family and friends and literature and aspects which are there. That's the general support and information. Extra support is, it could be volunteers, patient could be actually going into carer group support or bereavement group in the community itself. Or when it comes to specifically specialized professional support, counseling therapy, it could be psychiatry involvement also here for a person who is not able to cope at all. I think that is where palliative care services in a specialized there. This could be generalist palliative care which would be provided in the community itself. So these are the various step ladders for bereavement support. In the summary, what I'm looking at is you should have a routine screening of all your patients, and you should have a defined referral criteria in your hospital. And do we have in our hospital? Absolutely, yes. That's where Somshika sir told, saying that we're going to look into outcomes more than anything else. And automatically it should get triggered saying that it should go into outpatient palliative care services from the diagnosis of a life-limiting illness. Now, once you're there, increased timely palliative care access is there, and they will look into all the parameters from symptom control going to the last of bereavement, as I had mentioned, or patient has gone into survival and survival benefits, survival concerns of pain and rehabilitation. That's also going to be taken care. And once you've taken care, health-related quality of life is improved, and quality of life is going to be improved much, much better over here. Absolutely making the patient survival itself and longevity of life becomes much, much better. Now, to summarize, affirm that patient and family as a unit when you're actually dealing with a chronic illness. And the chronic illness criteria or the model which is required is quite different from the acute setting or model. And palliation is just not going to be hand-holding or end-of-life care. It starts from the diagnosis of a life-limiting illness, as well as it's going to go on towards the trajectory as much as treatment is going on. Access should be there for the patient as well as family members based upon their values, needs, and preferences. It should be entrusted upon saying that what is best beneficial from the treatment, disease management. It could be any form which they would like to. Could be radiation, surgery, could be medical, whatever they would actually look into. Not forgetting the evidence, not forgetting what is going to make them better in terms of their health-related quality of life. Now, access gaps could be there from the individual perspective, organizational and societal levels. All these concepts, if they are actually deeply percolated, could actually nullify all of this. And what is going to bridge the patient as well as the right kind of care, improving quality of life is the knowledge and the resource. And that is what we are all doing. Thank you all for actually being there for this wonderful class for the last 45 minutes. Thank you all. If you have any questions, anything, please let know. I'll be trying my level best to answer them. So there's a question from Dr. Kiran. Which is better, IV fentanyl or oral morphine for a cancer patient, severe pain in a metastatic disease? So it depends upon the setting. If the patient has actually come to the hospital and is in severe pain, you've got access to all the opioids possible. Now, if you have a patient who's actually having liver failure, kidney failure, definitely you're going to use IV fentanyl because your excretion is also very, very important. But at the same time, if a patient is actually not having any of this, and if the patient needs good pain relief, he's very anxious, he's not going to actually feel in any sense having concerns of elimination of the drug, morphine IV could be titrated in the emergency. Whereas if he is at home and it's severe pain, breakthrough pain, it could be. Breakthrough pain is going to be severe. At the home, you can give oral morphine itself. Now, OTFC, that is oral transmucosal pentyl citrate, is something which could be given at home for a patient who's going to be there. It actually works wonderfully, almost as effective as IV fentanyl itself. So depends upon the individual, the patient, the type of pain, as well as what's the setting. Now, access to any of this, I would say there is nothing saying that this is good, that is better. You will have to understand what is the setting to understand which is going to be better. And one size fits all as much as doesn't work, or one surgery or one chemotherapy does not fit all. It's the same way that morphine does fit for everybody might not be the truth. I hope that answers your question. So the second question, which is actually put across saying that by Dr. Divyang. So Dr. Divyang, I'm sure saying that when it is going to be there, if you have a life-limiting illness, which as a clinician you've understood, I've actually put across in the summary, slide itself. It has to be probably wherein you know saying that this is going to be life limiting. It is not going to be curable. That is the time wherein you need to actually start. So if you have referred, then if in the third stage, if a patient comes, you're going to be rehabilitating also. You'll have to look for post-treatment pains, post-treatment concerns, not just physical, psychological, socially, whether he's gone back to his work. So third stage could still be there when the diagnosis is made. So therefore, if palliation is just not end of life care, I hope my slides have actually answered your query to the best of its concern. So it could be as early as possible, wherein you feel saying that stage 3, stage 4, definitely yes, from the diagnosis itself. So that denial or depression, that's if you talk about communication, and if you feel saying that it's going to stop them from taking treatment, it depends upon how this has been put across, how this has been told, what is going to be there. Now, this is the common myth saying that people will go into depression or denial. Denial is a form of coping, but the right way, the right steps involved in actually managing that, communicating that properly to the patient as well as the family will get them back. And what are the benefits it's going to be is something which is important. So it is a communication concern. You need to actually communicate to them properly. And it is not just saying that patient is depressed, patient is going. So depression of treatment, the treatment for depression and others also is a part of pain and palliation. And this is something which we do regularly. And we do get these queries, not from our colleagues, from the family itself, who says, collude, that is, don't tell the diagnosis to my loved one. He will go into depression. He will not take treatment. But on the contrary, there is a gap between the patient as well as the family member saying that my kith and kin does not know what the diagnosis is. But unfortunately, they would definitely know. They don't communicate to each other to protect each other's interest as well as for the love they have. This is where it is. And it is something which has to be diffused. It needs specific understanding as well as training, but it's not something which is not doable. When to use transdermal patches and how the dosing adjustment are done. So when a patient comes to you in an acute setting and a person is actually in severe pain, as somebody just now asked, you have to have a IV titration going on and see whether that titration is fine. A very good question is put across saying that post-surgically, can we apply a fentanyl patch and think saying that it's going to work? Definitely not. Because patch takes at least 12 hours for it to actually form a steady state in your lipid layer, and then getting into your capillaries and actually getting a full steady state is going to be 24 hours. Now, fentanyl patch should be applied when in your background pain is something which is specific, you've understood that, and you know that this is the requirement of the patient. Unless and until you don't know the requirement, you cannot apply a patch. Any role of initiating analgesics from day one of radiation therapy? So intervening over here might not be just analgesics. Physically is something which you can talk about analgesics, but how it is going to be, how much it's going to cause concerns, what are the things which you're going to do if there is pain, if there is going to be dryness, if there's going to be mucositis, it's going to be fungal infection, it's going to be purulent discharge, bleeding. These are certain aspects, not to scare them. I understand if you scare them, it's going to be difficult, but giving literature, building knowledge, telling them this is what is expected. Get back to us if you have any concerns, but we are going to stand steady next to you, and we're going to manage all your symptoms so that you will be able to complete your treatment. If you give the assurance from the day one, that itself is a boost for them. They would accept this much, much better, and they would be really, really reassured. And initiating, if the patient has got severe pain and the ulcer is big, huge, fungating, now just not giving a tablet of morphine or paracetamol or any of the other medications. It could be cleaning. If there are maggots, removing the maggots. If there are other things, purulent discharge, giving appropriate antibiotics, appropriately managing them, and facilitating how to eat, how to drink, what not to eat, how to sleep, how to get up. All these things become very, very important. So just not one medication could help. It has to be individualized based upon that patient and how we can take it ahead. any further questions, kindly post them. Do we have any further questions? Sir, it looks like there are no other questions. Should we wait for another 2-3 minutes? Drug of choice in mucositis. Question by Dr. Yuvraj. So it could be fentanyl itself. If you have got access to it, PCA fentanyl would be the best. And if the patient is at the hospital setting, and if it's grade 4 mucositis, you need to get down that pain very fast. But if mucositis is grade 2, grade 3, even simple medications also, step 1, step 2 medications could also help. Now, right kind of gargling, the right kind of medications to be taken, stepwise understanding how it should be done. Simple salt and soda gargle, the mucane syrup with lignocaine viscous, taking 5 minutes before food, how to keep it, how much to swallow, what not to swallow. These attention to detail becomes very, very important. And any drug which is acting locally is the best. Systemically is something which you use, but depending upon the severity. If it's severe, yes, IV fentanyl, IV morphine, oral if patient is at home, anything could be used. As I told, it is much, much specific and it has to be individualized. Can we use tapentadol in place of tramadol, and is there benefit with tapentadol? Yes, I strongly use tapentadol a lot. The main reason being is a better congener to tramadol. The side effects of nausea, vomiting, the tolerance is a little bit better. Now, the concerns of constipation is going to be higher in tramadol compared to tapentadol. And one more thing in tramadol is extended releases are not available. Tapentadol has got an extended release which can work up to 12 hours. So therefore, yes, I would definitely accept when there is mild to moderate pain. When going to severe pain, tapentadol could be drug of choice, going up to 600 mg per day. There's a doctor from Dr. Guru Swami here. Sir, please explain transfentanyl patches in pain relief treatment. Now, over here, what happens is when you are actually requiring a patient who's actually having the steady state pain, then you want that patient to have a pain relief over a period of time. Now, if the compliance becomes a concern, patient has got intestinal obstruction, malignant bowel obstruction, nausea, vomiting, his oral intake and absorption is going to be doubted. That is where you're going to put your fentanyl patch. For not all patients, I've seen saying that post-surgical, post-radiation, or radiation is going on, patient is in severe pain, just apply the patch, might not be the right concept. Titrating the patient, understanding how much it is something going to be there. I think explaining of transdermal fentanyl patches, if you want a specific class, cancer pain is something which is going to be a 2 hours class, and that is something which is going to explain to you much, much better. I think you can request for that. Definitely, I will be more than happy to take that class. Dr. Kiran, role of DNR consent in palliative care in end-of-life care. Advanced directives are already there. Advanced care planning is important. Now, if you actually have the diagnosis and the management side by side going on for all the stage 4 cancers, we know saying that it's going to be palliative intent, at least in them, non-escalation is something which is already there. Now, the Supreme Court has come up with a verdict last year, 2023 itself, that this aspect of just do not resuscitate could be a common terminology. That is cardiopulmonary brain resuscitation is not something which is going to be there. There is chest compressions, intubation and ventilation is something which we are against. But IV fluid, antibiotics, appropriate for that setting, for that patient, for that concern is something which we still advocate. Even electrolytes, even in patients who are dying, calcium corrections, which is going to make them better, is something which we will have to continue. So DNR is not for stop everything or ignore the patient or patient should be abandoned or just sedated and left over. No, it is not. It's a bigger concept altogether. Dr. Bhavana has asked for, is methadone better or morphine, sir? So methadone requires a specific understanding of what the treatment has to be. And it is a specialized person who could deal with methadone. Everybody cannot deal with methadone. Morphine is something which is the basic rung. Morphine is not wrong or right, but there are specific instances where methadone is better. It could be opioid-induced hyperalgesia. That is where we can use, wherein a good amount of morphine is used and still patient is not having better pain relief. Expected in neuropathic pains, severe neuropathic pains, then definitely methadone could be used. There are specific conditions wherein side effects are more, so therefore methadone could be actually as a changeover drug could be used. And methadone is safe in the right kind of hands because it has to be dealt with by a specialized person, because the drug interactions with methadone is going to be very, very high in comparison to morphine. Dr. Suryakanta has asked, sir, please explain morphine dose calculation. I think over first 24 hours to 48 hours, you're going to give morphine. Morphine works only for 4 hours. If a poor patient is naive, that he is not started morphine at all, every 4th hourly you can tell if a patient has got more than a score of 3 on a numerical rating scale to take morphine of 5 mg and check whether that pain is going to be better for how long and how much is required over the next 24 to 48 hours. 48 hours is better. Calculate the dose of 48 hours of all the 4th hourly dose, and then you actually calculate that 48 hours divided by 2, you're going to give it for 24 hours. That 50% is what is going to be the medication of choice which are going to be there. And 1/6 of that 24 hours is going to be the breakthrough. I know that I'm not doing justice by answering that in that fast manner. It requires an approach. It requires a table. I'm sorry, I'm not able to actually completely convey that in that short while. In our step up, Dr. Abhishek Verma has asked, sir, in our setup, we have generally seen that diclofenac has been more helpful in alleviating pain than tramadol tablets in most patients. Sir, what is your experience? It depends. If it's an inflammatory process which is going on, definitely it is going to be much, much better in diclofenac. But at the same time, difluclofenac could not be given for a patient who's going to have renal issues. Now, if you have a cisplatin or oxaliplatin-based treatment going on, and you know that it's going to be nephrotoxic, and you're going to have a dehydrated patient for head and neck cancer, and you put diclofenac over there for a mandibular nerve pain, obviously it's going to be much, much more worse. You could use steroids over there when radiation is going on. You could use other things, nerve blocks, so many other things are there. I'm not telling diclofenac is bad, but individualize that is most important. For as far as possible, I'm very, very cautious when I'm using NSAIDs and at a limited approach. I would not take it as a generalized approach. Please take it 3 times a day or 2 times a day. That would not be my approach. So tapentadol, tramadol, diclofenac, paracetamol, as well as the adjuncts, gabapentinoids, triptomer, it could be carbamazepine, it could be others, have definitive role. And not to forget, constipation and other side effects has to be managed. And that is something which is going to be important for the patient to improve quality of life. Dr. Sarhana has told, sir, please add a note on opioid conversion calculation simplified. Dr. Sarhana, I think most of you have asked for opioids. Please request for another class. I will take for another class for sure. It's very difficult. You will be able to get the opioid conversion table on the Google itself. But how to do it, we should have a case-based discussion and then take it ahead. I think it's 8:33. We'll have to end the class here. Sir, I'm going to end the class. Is that okay?
Yes, sir.
I think they need 2 classes on opioids and opioid conversion, and as well as how to manage cancer pain. I think I will also put it across to Professor Somshekhar, sir. Please put it across. We can actually deal with it easily. Okay?
Yes. Yes.
Thank you all for attending early in the morning on a Saturday. Thank you all.
Thank you all the attendees and faculty members for the opportunity. Thank you, sir. Thank you so much.